Hi, my name is Ellen and I'm a student at the University of Michigan School of Nursing. I'm now going to present a patient to you. The patient is a 71-year-old married Caucasian female. She was a beautician and is now retired. She was admitted at Heartland Healthcare Center on May 13, 2013. The patient reports admittance for peripheral neuropathy that is causing pain in her lower vertebrae and a loss of sensation in her lower left extremity. The chart stated that admittance was due to gait instability and frequent falls. The patient records having this problem for a couple of years, but the pain got worse 1 year ago when she had to start using a walker. Patient reports falling 3 times at home prior to admittance at Heartland. Patient reports that she has had type 2 diabetes mellitus for 10 years that is related to the neuropathy. Prior to being admitted at Heartland, the patient used a heating pad and prescription drugs as treatment. While on pain medication at Heartland, the patient reports her pain as a 5 on a scale of 0 to 10, 10 being the worst pain she has ever experienced. Without the pain medication, she reports that this number is a 9 or a 10. Aggravating factors include waking up in the morning while lying down, and an alleviating factor is sitting up in bed or in a wheelchair. Her neuropathy has a big impact on daily living because it is hard for the patient to be mobile. The patient has a history of high cholesterol, hypertension, and diabetes mellitus. The chart reports a history of dementia as well. She recently came off of her cholesterol medication, simvastatin, and she is up to date on her immunizations. The patient and her records report allergies to penicillin and sulfa that cause hives and dyspnea. Past hospitalizations and surgeries include the removal of the patient's tonsils as a child and the removal of her gallbladder. The patient's current medications include proton pump inhibitors for gastroesophageal reflux disease, metformin for diabetes mellitus, albuterol for asthma, and amitriptyline for depression. The patient denies any use of alcohol or drugs. The patient reports a low level of exercise outside of physical therapy at Heartland for the past few years or weeks. The patient reports poor sleep since admittance at Heartland. Patient reports a healthy, balanced diet with the occasional soda or coffee. Patient reports being well educated on diabetes and taking care of her diabetes. Patient lives at home with her husband and 2 teenage granddaughters. She reports that she has no major stressors and that she sees her doctor for regular checkups. Her highest level of education is beauty school. Her father had lymphoma, her mother had dementia, and her sister and only sibling had muscular sclerosis. Her vital signs were 142/62 for blood pressure, pulse rate of 67, a respiratory rate of 18, and a temperature of 98.2 degrees. For the review of systems, a respiratory exam and a peripheral vascular exam were performed. The patient denied any shortness of breath and history of pneumonia or bronchitis. The patient reports having asthma and needing an inhaler for emergencies. The chart reports the use of albuterol. The patient denies having a productive cough and denies having frequent upper respiratory infections. The patient denies any pain or wheezing with breathing. For the peripheral vascular review, the patient reports a loss of sensation in the lower left extremity. The patient denies any edema, unusual coolness, or hair loss on her extremities. The patient denies a history of blood clots in legs and a presence of varicose veins. Upon inspection for the respiratory exam, the patient's AP transverse diameter ratio was 1:2. There was no sign of injury, and the chest appeared symmetrical anteriorly and posteriorly. The patient's breaths were normal in depth and rate. For palpations, the trachea was aligned and felt intact. Expansion posteriorly was normal. There was no crepitus, and tactile fremptus was normal with diminishing vibrations from upper to lower lungs. During auscultation, all fields were clear anteriorly, posteriorly, and bilaterally. Bronchophony, egophony, and whispered pectoriloquy were normal with no indications of consolidation. No wheezing, crackles, or other abnormal findings were presented. For the inspection portion of the peripheral vascular exam, there was a pallor of the lower extremities. There was edema of the wrists, hands, ankles, and feet bilaterally. There was no hair on the lower extremities and no visible wounds or injuries. There were no varicosities. For palpation, the temporal and carotid pulses were +2, while the brachial, radial, femoral, popliteal, posterior tibial, and dorsalis pedis were all 1+. The patient had poor capillary refill in both the fingers and the toes bilaterally. There were no varicosities found upon palpation. The patient denies any tenderness of the lower extremities. Edema in the extremities and cool and dry skin were found during palpation. Another important system to review and examine would be the integumentary system. According to the article Skin Signs in Diabetes Mellitus, diabetes can cause problems with skin homeostasis and metabolism that is associated with vasculopathy and neuropathy. The article also states that diabetic patients will have complications with delayed wound healing and impaired epidermal barrier function due to the influence of insulin on keratinocyte proliferation. Due to the patient's comorbidities, it is important to provide a complete skin examination. Another important system to review and examine would be the neurological system. According to an article on peripheral neuropathy can negatively affect motor nerves in the body by relaying information from the brain to the body's organs, skin, muscles, and joints insufficiently. Symptoms can include muscle weakness, mobility difficulties, and falling. A full neurological examination should be done with the patient to assess her general motor function and general sensory function. This is important to understand the extent of her neuropathy.